right, so we're going to start off with a case presentation. We have a 3-year-old female who's brought in by her mother. Mother complains of nasal congestion, dry, non-productive cough, and a fever. Mother also states the child's not been eating or drinking as well, is more irritable, and is not sleeping very well. On vitals, you note a fever of 101.2. On physical exam, you note clear rhinorrhea, an erythematous, bulging right tympanic membrane, and rest of physical exam is within normal limits. Some of the differentials you may include are upper respiratory infection, influenza, bronchitis, but due to the physical exam, this is acute otitis media, which is defined as inflammation of the mucosa that lines the middle ear. In this presentation, we'll be talking about the etiology and pathophysiology, the signs and symptoms, physical exam, as well as diagnosis and treatment of AOM. Etiology and pathophysiology. About 60% of children less than the age of 5 will get acute otitis media. Peak incidence is around the age of 1 or younger. Studies have found that males are only slightly higher affected than females, and race does not play a role. Some of the common causative agents are S. pneumoniae, H. influenzae, and S. pyogenes. Due to the introduction of vaccines, H. influ is not as common. The most common is S. pneumoniae. There's been other studies done to look into other pathogens such as Allococcus and Staphylococcus organisms. There are multiple risk factors with AOM, including a concurrent or previous upper respiratory infection, cigarette exposure, daycare, and breast first formula feeding. It's actually been found that breastfeeding for at least 6 months can reduce the risk of getting AOM. And the patient presented in the case, she is 3, which falls into the age category, and she was experiencing some signs and symptoms of a upper respiratory infection. Further questioning of daycare, cigarette exposure, things along those lines could have been helpful as well. So some of the signs and symptoms, this table is taken from a study done by Pichachiro. He looked at 363 children with AOM and found the most common symptoms listed here. As you can see, cough, rhinitis, those are the most common, which correlate with also having upper respiratory infection. Fever, needs to be greater than 100.4. Shouldn't be a very subjective fever by mother. It's important to check it in office. Irritability is also very common. It's important to note that earache and ear tugging are the least common symptoms. A lot of people think that with having an ear infection, you would have, either a child complaining of an earache or the nonverbal children pulling at their ears, messing with their ears, but that is actually not a common symptom. So it's important to note to always look inside of the ear when doing an exam. In the case presented, the child's mother never reported any signs of an earache, but she did have the cough and the irritability and a fever. On physical exam, before looking in the eardrum, looking to see the eardrum, it's important that the lighting's adequate. You remove any cerumen that may be obstructing the view, and that the child's positioned in a way that you can easily look at the eardrum and not have them moving all over. When you do look at the eardrum, you'll see a bulging and erythematous eardrum. Here you can see a normal eardrum versus one with AOM. It's very red, it's bulging. You can't see all your landmarks as well. When doing a physical exam, important to look at the eyes, ears, and throat. Rule out any other differentials that may be happening. You might see some rhinorrhea or some conjunctivitis going on, as well as a fever. In our case, this child presented with exactly what an eardrum of AOM would look like, and she also had a fever. For diagnosis, it's mainly a clinical diagnosis, looking at the symptoms in the physical exam. But there is this scale called the Acute Otitis Media Severity of Symptom Scales. It identified 7 different symptoms that can help aid in the diagnosis. Those include tugging of the ears, crying, irritability, difficulty sleeping, decreased activity and appetite, as well as a fever. Labs and imaging are not traditionally used for fevers that remain high despite adequate treatment. may be important to order a CBC, ESR, look at maybe possibly doing blood cultures to figure out what could be causing the fever. For treatment, antibiotics are always the go-to choice for acute otitis media. Augmentin is the number one choice. Important to do a full 10 days worth of treatment. There have been studies found that doing 5 days first 10 days is not as successful, so it's important to educate parents to take the antibiotic for the full 10 days despite if they feel better or aren't having as many symptoms. If the patient has an allergy to penicillin or has an unknown penicillin status, it's best to use Bactrim. For fever, pain, over-the-counter acetaminophen or ibuprofen, or alternating the two to help control those. Important to always have a follow-up in 2 weeks, or if symptoms worsen, for them to come in sooner. The child may not be experiencing or showing any signs or symptoms, but it's important to look at the eardrum and make sure that the infection's completely cleared. You also want to educate the parents on keeping some water out of the ear, as well as ear drops, just to try to give that whole ear canal and eardrum time to heal and fully recover. Back to the case being presented, with her having the acute otitis media, you would definitely want to treat with the Augmentin for a full 10 days, have them come back in 2 weeks, and reassess then. If the symptoms have not improved or have seemed to gotten worse, switch to cephalosporin or fluoroquinolone, or from then you can refer to an ENT. And here are my references.